Today I'll be talking about some of the research projects focusing on the FGM services evaluation that I've been engaged in during my graduate education. And before I start, I'd like to thank my collaborators and my dissertation committee as well. Dr. Angie Carlson, Dr. Rachel Applehouse, Amanda Brummel with Fairview, and Dr. Schomer at the University of Minnesota. So as for the disclosures, only Amanda Brummel, she is an employee of Fairview Pharmacy Services. All the other authors have nothing to do with it. So this morning, the learning objectives for my study is, by the end of the study, by the end of the presentation, hopefully we'll have a better understanding of the patient factors which are associated with exposure to FGM services at a higher rate. We'll have to better understanding as well of the impact of FGM visit frequency on the meeting the optimal diabetes clinical outcomes, and explain the overall role that FGM services can play in helping the patients achieving the optimal management for patients with chronic diseases. So this is my self-assessment question, and hopefully by the end of the study we'll be able to answer that. So what are the factors which affect the number of FGM visits that a patient should receive more? Are they the demographic characteristics, disease-related characteristics, or medication regimen complexity characteristics? So our scan of the literature showed a lot of barriers to wider adoption and access to FGM services. In my graduate work, I focused on some of those barriers, mainly to understand the factors which affect the intensity at which the patient gets exposed to FGM services. I'm talking specifically about the face-to-face services. Secondly, doing a rigorous assessment of the FGM services contribution to meeting the optimal diabetes and optimal chronic diseases clinical outcomes measures. And thirdly, to measure the potential contribution or the return on investment of FGM services on the economic outcomes. So this morning, I'll be talking, this presentation is focusing on the first two needs only, the factors affecting the intensive exposure and the contribution of FGM services to the quality improvement to meet the clinical outcomes benchmarks. So those are the two aims: clinical and evaluating the clinical and drug-related factors which affect the frequency at which patients receive FGM, and determine whether patients who receive FGM services at a higher frequency, are they more likely to meet the optimal diabetes outcomes benchmarks or not. So our study sample was composed of a cohort of diabetes patients who were exposed to FGM services during a demonstration project in 2007. We split our group into two based on the mean and median number of visits, which was 4. So we had two groups of patients, patient who had less than or 4 visits or less over a 1-year period in 2007, and the high frequency group which had more than 4 visits in the same year. We used the medical records to evaluate the baseline characteristics of the patients, namely the age, gender, their diabetes status, whether they had complications on top of diabetes, other chronic diseases like hypertension, hypercholesterolemia, asthma, cardiovascular problems. We used that also to compute the Charlson score index, a measure of comorbidity. And we also built 3 categorical variables to measure the medication regimen complexity, specifically for diabetes drugs, hypertension, and hypercholesterolemia. So for the diabetes, we determined for each patient whether the patient was taking insulin or not, because usually patients taking insulin are having a more challenging regimen that require much more efforts to be adherent. And for the hypertension, we built 3-level categorical variable, whether the patient was taking any drugs for treating the hypertension, whether the patient was taking ACE inhibitors or angiotensin receptor blockers, or the patient's 3rd level, which is taking ACE and ARBs plus other medications as well for the hypertension. And for the cholesterol, we determined whether the patient was not taking any drugs for cholesterol, taking statins only, or taking statins plus other medications as well. Optimal diabetes care was measured using the D5 measure, which was reported by Minnesota Community Measurement, a not-for-profit organization in Minnesota, which is involved in public reporting of outpatient clinics' performance, which have been used lately in the last 4 years for within the framework of pay-for-performance initiatives as well. We had those measures for all the patients in the study in 2006, before the patients were exposed to NTM, in 2007 when they were exposed, and then in 2008, 1 year after the service stopped. The D5 is an all or none composite measure of diabetes care, and the 5 components are whether the patient met the HbA1c less than 7% or not, LDL levels were less than 100 milligrams per deciliter or not, blood pressure less than 140/90, and whether the patient stopped smoking or not and was taking aspirin daily. All of those 5 components were treated as binary variables, 0 or 1. So first, we compared the baseline demographic and clinical characteristics between the 2 groups, the high-frequency group and the low-frequency group, using the t-test for the continuous variables and the chi-square test for the categorical variables. And then we moved forward trying to model the factors which affect the probability that a patient is a member in the high-frequency group. So for that, our first choice was using a logistic regression. However, as we're going to see in the results, we had sparse data problems. Some of the variables, which were some of the binary variables, all the patients in the high-frequency group had that variable as 1. So that caused problems in the model convergence. So we had to abandon the frequentist approach and we moved to a Bayesian approach to solve this problem. And for that, we used a multivariate Bayesian logistic regression with a weakly informative prior within using the Gibbs sampler. And once we were done with that, we had estimates of the odds ratios. So to facilitate the interpretation of the outcomes, we converted the odds ratios into relative risks using the method of recycled predictions. And then following that, to answer the second question, we compared the values of the optimal diabetes measures between the 2 groups in 2006 and in 2007 using Wilcoxon rank sum test for the real values of the measures, the HbA1c and LDL, and chi-square test to just compare the proportions of patients meeting those goals. So for at baseline, the 2 factors that were significantly different between the 2 groups were the patient insulin therapy. So it was at 70% in the high frequency group, whereas it was 45% in the low frequency group. And the percentage of patients who were taking statins plus other medication for their hypercholesterolemia was significantly higher in the low frequency group. And as you can see, the 4th variable, percentage of patients having diabetes complication, was 100% in the high frequency group. And this was the main variable which forced us to move to the Bayesian framework. One potential solution could be removal of that variable from the model, but actually we were interested in evaluating the impact of that variable, so we didn't want to take it out. So what are the results of the Bayesian logistic regression? So basically the 2 significant factors are the diabetes complications, second variable, and the taking insulin. Those factors were associated with higher probability of being a member of the high frequency group. So the diabetes complications, the posterior estimate of the relative risk was 4.63. So patients who were taking insulin had 4.63 times the probability of being in the high frequency group, which means having more than 4 visits annually of NTM compared to the low frequency group. And patients who were taking insulin had 2.23 times the probability of being a member in the high frequency group compared to the low frequency group. Other factors were not significant predictors of that membership in the high frequency group. As you can see that their lower and higher confidence intervals cross the 1, so they are not significant. And then we compared the D5 care components between the 2 groups over the 3 years period. So as you can see, in 2006, the proportion of patients who were meeting the optimal score altogether, which means meeting the 5 components at the same time simultaneously, was significantly higher in the low group, which was expected, and it was significantly higher also for the HbA1c level. Almost 54% of the patients in the low frequency group were meeting the HbA1c goal, less than 7%, whereas almost 24% were meeting that goal in the high frequency group. However, upon exposure to NTM services in 2007, those differences technically vanished. Most of the p-values were insignificant in 2007, with the exception for LDL, which was noticeably higher proportion of patients were meeting their LDL goal in 2007. And then once the program ended in 2007, we followed up those patients 1 year after that program ended as well, and we recorded their values in 2008. And there was no significant difference across all the components, with the exception for the blood pressure, which was still significantly higher for the high frequency group. And then following that, we did kind of a pre-post analysis on the high frequency and the low frequency group, comparing the 2006 and 2007 values within each group itself. And we noted that for the HbA1c level, it was significantly reduced from 2006, pre-NTM, to 2007, post-NTM, for patients in both groups. So patients who were in the high frequency group and patients who were in the low frequency group, both of them had significant reductions as compared to themselves in 2007, whereas for LDL, it was significant only for the high-frequency group. It had a significant reduction in their values, whereas in the low-frequency group, actually their values increased, and it crossed the 100. Their mean values crossed the 100 limit. So those were just comparisons of the actual values of the HbA1c and LDL levels. So from that study, we found that the patients who had diabetes-related complications, as well as patients who had taken insulin as part of their medication regimens, had a much higher probability to receive more frequent MTM visits. Our prior hypothesis that the hypertension and hypercholesterolemia regimen compositions would affect that chances was not true, so it did not have a significant impact on the patient likelihood to receive more MTM visits. Also, it seems that the HbA1c levels are very sensitive to receiving MTM services. So patients who were both in the low frequency group and the high frequency group, both of them had significant reductions in their values moving from 2006 to 2007. However, the LDL was not as sensitive. It was only affected in the high frequency group who had more than 4 visits. Whereas for the low frequency group, actually their values in 2007 upon exposure to MTM was higher. So the key points, take-home messages from that work is the disease and the medication-related factors have the greatest influence on the frequency at which the patients receive their MTM visits. Pharmacists can really play a significant role in helping the complex patients meeting their nationally recognized quality measures of clinical care. As we have seen that the proportion of patients meeting their optimal care limits, the proportion has been increasing upon exposure to MTM services. So now I'll end with a self-assessment question, and I hope we can all determine which are the factors which were significantly associated with being exposed to MTM services at a higher level. And with that, I finish my presentation, and I'm going to go to your questions.
I was wondering, I think this study is really well done, so congratulations for the good work. I wanted to ask a question related to your decision to classify the number of visits to using this threshold of 4 instead of analyzing number of visits as quantitative measures.
That's a great question. So actually, I'm just showing the sensitivity analysis. Our published article contains a primary analysis in which we used a negative binomial regression. And we did exactly what you said. We used the number of visits as a continuous variable. And the same 2 factors were the same factors which were significantly predictors of the number of visits. However, we also we wanted to do like a split at the mean or median number of visits, and we had a discussion with the clinical pharmacy practitioners who were providing the MTM, and we reached the decision that patients who have more than 4 MTM visits per year, they consider them as high-frequency visits, so they are having more complex profiles, so they wanted to know what are the factors which are associated with seeing the MTM at that high level. So we did both analysis. So we did the same.
That's good. And the statistical software that you used to run the Bayesian logistic, what was that software?
SAS.
SAS, okay. Thank you.
Sure.
Perhaps as a follow-up question, were the number of visits driven by a study protocol, or was it the practitioner making a decision that they would ask the patient to return, or was it the patient asking to be seen again, or was there some combination?
It's a combination of both patient factors and the pharmacist or the MTM pharmacist factors. But the thing is, even if the MTM pharmacist asked the patient to set an appointment, the patient could not show up. So it was a mixture of both factors, but we didn't have exact data on what was the driving force for that. But those things I'm just telling you from my discussion with the providers.
So there was no study protocol?
No, there was no, it wasn't a study protocol. There was no specific study protocol.
I think this is great work, Ahmed. I just had a question. What are your thoughts, so in terms of the differences between diabetes and hypertension and cholesterol? I was wondering if what are your thoughts about what the difference, where that difference is coming from, and if does that have to do with actually diabetes having more symptoms than cholesterol or hypertension, and this may drive actually patients to actually go to and get pharmacists' help.
So you're talking about the factors that would affect the frequency of visits for diabetes patients specifically versus hypertension?
What your first finding, yes.
That's a good point, and we had a discussion about that. What we think is, specifically patients who were in the high frequency group, most of them had a high proportion of them using insulin. So and insulin, is a very dynamic regimen. So it seemed that there's a highly sensitive impact for meeting the MTM pharmacist on the patient performance. That might be helping the adherence to insulin. So supposedly the counterfactual mechanism that patients are not meeting the pharmacist, so maybe they're not as well adherent to their insulin therapy, so which causes like reduction, like increasing their HbA1c levels and not meeting the goal. So those were the factors we thought might be relevant to the results that we found.
Yeah, because I'm looking at it, from the self-regulation, and how if I was a patient, if I was in their shoes, how, I've had these symptoms, especially with, as you mentioned, the ones who are using insulin maybe under, Good work. Good work.